Helicobacter pylori, one of the most interesting bacteria in human infections. Why interesting? Because around 50% of world's population harbors this bacteria. This is one bacteria which can survive in a very acidic pH, even up to 1 to 2. There is one bacteria which has been directly linked to carcinomas. This bacteria causes gastritis, and this basic understanding was brought about by Barry Marshall and Robin Warren, who got Nobel Prize for this. To understand this bacteria, scientists drank the bacteria, developed gastritis, and treated it to prove that this bacteria is associated with gastritis. Interestingly, the same bacteria can also protect against some diseases. So let's see more about this. So Helicobacter pylori is a bacteria which is associated with the peptic ulcer disease and sometimes gastric carcinoma. It nicely colonizes the stomach. It's a curved gram-negative bacilli. So it is mostly seen only in man. As I told you earlier, more than 50% of world's population has this bacteria, and the patients may acquire this bacterium in childhood, and it might persist in adulthood and even. So this bacterium is highly motile. It has 4 to 8 flagella. This will be in an environment where there is a lot of mucus, which is laying on top of the gastric mucosa. So what it does is basically produces a enzyme, which is a urease enzyme. So what it does, it will basically catalyze the urea. So when that catalysis happens, a lot of ammonia will be produced, and this ammonia will buffer the acid around it, bringing the pH to an alkaline level near the bacterium. It also has amidase and arginase enzymes, which can also help in production of ammonia. Then it has adhesins so that it can attach nicely to the mucus layer. A small percentage can bind to this mucus epithelium by using the adhesion molecules. So some of them are somewhat like Lewis blood group antigens. They will also adhere with the lipoproteins. The oxidative stress, the H. pylori produces many detoxifying enzymes that can protect this organism against the free radical damage caused by the host own metabolism. So once the bacterium settles down, it has a basic property of creating vacuoles in the cells, the cytoplasm of the cells. So what it does, basically it modulates the host cell metabolism. There are some differences in the cell arrangement, morphological changes, some new antigens like proto-oncogenes are presented. It also releases pro-inflammatory cytokines from the gastric epithelial cells. This bacterium basically acts with the principle of molecular mimicry, where the lipopolysaccharide of this bacterium is identical to Lewis blood group antigen, which is expressed on the parietal cells in the gastric mucosa. So what it does, immune tolerance by downregulating the T cells, induction of autoantibodies that cross-react with the mucosal epitopes, so that leads to chronic active gastritis. The lipopolysaccharide will also inhibit glycosylation and sulfation of gastric mucus. So the protective function of the gastric mucus is lost, and the surface is more now susceptible to the gastric acidity. What are the factors which are associated with the development of gastritis because of H. pylori? I have this people with polymorphisms with cytokine genes like IL-1, that is interleukin 1, or genes coding for toll-like receptors. They have a higher risk. Obviously, people with smoking or people who consume high salt diet are also a risk for developing cancers. Diets which are very much high in antioxidants and vitamin C may be protective. Clinically, what do you see? You see a good amount of gastric, that is acute gastritis, wherein the antrum part is involved. The cardiac end is not involved. Then you have the antral gastritis, which can predispose to duodenal ulcers. Pangastritis, which can later on lead to adenocarcinoma of stomach. and peptic ulcer disease where 70% does duodenal ulcers and 50% does gastric ulcers because of this bacteria. How the ulcer is formed? Basically, this bacterium induces inflammation by inhibiting somatostatin D producing by D cells, increases gastrin release. So what will happen with every time the patient eats food, there will be higher acid secretion. This will induce a duodenal ulcer and gastric metaplasia of duodenal mucosa. The gastric ulcer, where there is a hypochlorhydria, despite the increased amount of gastrin release, there will be epigastric pain with burning sensation, which is the most common presenting complaint. The patient can either develop a duodenal ulcer, wherein the patient will have pain after eating, or an empty stomach, where in the case of a gastric ulcer. So basically, the consequence, if you look at it, it is like the one is most common thing is chronic atrophic gastritis, autoimmune gastritis or pernicious anemia, adenocarcinoma of stomach, and gastric mucosa associated lymphoid tissue lymphomas. As I told earlier, this H. pylori can also protect in certain conditions, like it can protect the patient from developing gastroesophageal reflux disease, Barrett's esophagus, adenocarcinoma of esophagus, as well as allergic disorders, including asthma. Lab diagnosis, you can classify them into two types, invasive and non-invasive. So invasive test, you have to go for an endoscopy, take a biopsy from the gastric mucosa, both from the antral and the corporal region. You can do a histopathology with Warthin Starry silver staining. You can make it better or more specific by doing immunostaining with a H. pylori antibody. The other methods, you can do a gram staining where you're going to see a curved gram-negative bacilli with a seagull-shaped morphology. Culture you can do, but it's not highly sensitive because so many patients, more than 50%, might have the bacterium but not be developing the disease as such. So the culture media, what is commonly used is a Skeraus medium and chocolate agar. Plates are incubated 37 degrees Celsius under microaerophilic conditions with 5% of oxygen. Identification, you can do a Malitov or a conventional biochemical test like a urease test. There's something called as a rapid urease test, wherein it detects the presence of urease activity in the gastric biopsies by using a broth that contains urea. So this is what the colonies look like. All the pictures are taken from various sources just for educational purposes. Non-invasive test, you can do a urea breath test where the patient drinks a solution of urea labeled non-radioactive carbon and blows into a tube. The urease is produced by the H. pylori is present, and the urea is hydrolyzed and labeled carbon dioxide is detected with samples by mass spectrometry. So that what is the use of this? It's a test to detect live bacterium. It's more consistent and accurate, more sensitive, quick and simple, and it can be used to monitor treatment response. The another method is a fecal antigen assay, non-invasive test with 90 to 95% of sensitivity and specificity. This test can be used to detect both live and dead bacterium. So after treatment, to monitor the response is useful screening for children. You can also use an antibody detection by ELISA, which can be used before screening for endoscopy and for doing epidemiological studies. Treatment-wise, treatment is indicated when it's very clear the patient is having active or past history of peptic ulcer disease, atrophic gastritis, mild lymphomas, or following endoscopic resection of an early gastric cancer. Treatment is not recommended for asymptomatic colonizers or as a primary prophylaxis for gastric cancer because of the risk of adverse side effects and also development of antibiotic resistance. Just like in many other infections, here also you use a multi-drug regimens. So the success depends on how stringently the patient can follow up the regimen and obviously the sensitivity of the antibiotics. Two regimens are used. You have a one which is quadruple therapy where you use omeprazole, bismuth, metronidazole and tetracycline for 14 days. The other one is omeprazole plus clarithromycin plus metronidazole or amoxicillin for 14 days. That is used only if the H. pylori is sensitive to clarithromycin. After that, the treatment procedures, you can follow up with the urea breath test. If it's positive, the same course is repeated once more with a quadruple regimen. If it still remains positive, then treatment has to be based on culture of endoscopic guided biopsy followed by antibiotic sensitivity report. So to sum it up, you have a bacteria which lives with the patient for a long time. It has a urease enzyme so that it can survive in acidic environment, convert into alkaline in the areas where it lives. It's a motile bacterium. It has some toxins which can produce vacuolations. It's a major cause of peptic ulcers. The most important way of investigation is by endoscopic biopsy, urea breath test, or fecal antigen assay. Treatment wise, you have these regimens where you use omeprazole, bismuth, metronidazole, and tetracycline. So that is about H. pylori. I hope it was simple and short. Please like, share, and subscribe to my channel. Thank you.